I truly wonder how we justify keeping someone like him alive. For any nurses that are out there that are watching this, when you have patients that are complete... So let me tell you something about Ben though, because Ben said some pretty weird to me. It's funny because I promised myself I wasn't going to be too attached to my emotions when I made this video. In this video, I'm going to share with you my experience on working on a long-term psych geriatric unit while working at the state hospital. And I want to mention, well, okay, before I go into that, I just want to thank one of my viewers. I made a video recently and she gave me $5 for making the video. I think it's a she. I don't actually know if she mentioned she was a she or not. So ECT, I wanted to give a shout out to you, and I apologize if I am falsely attributing some sort of gender to you. I'm just guessing your gender based upon the way that you write. So hopefully you'll accept my prejudice. If I'm wrong and you're male, I apologize. But thank you so much for the super thanks. Like, it's incredible. I can't believe someone would actually pay me money to make a video. Well, not to make a video. You didn't pay me to make the video. You asked for me to make a video, and then I made a video, and then you paid me. It's just amazing. So thank you so much. I really appreciate it. So what I want to talk about in this video, well, before I get into what it was working like on this ward, I just want to say something. So this morning I was going for a walk and I was thinking about what kind of video I should make. And I was like, oh, I should tell about my experience working on a geriatric unit at the psych hospital. And I'm kind of recounting some of the memories and experiences that I had there. And then I thought to myself, oh my God, dude, I think I've actually experienced some trauma. And I'm laughing because I don't want to re-experience it. And I think I've just suppressed a lot of it and repressed. I think repressed is something you do subconsciously. So I think I probably have a lot of repressed memories from working at the state hospital, and not necessarily just this geriatric unit, but all the units that I worked on when I was at the state hospital. And I was just thinking about some of the memories that I had, and I was like, oh my God, bro, you have forgotten so much. But as I was walking and I'm thinking about it, like these memories are coming to me, and I'm like, oh man. And I think the reason that I've suppressed so many of them is because you see so many people who are in very dire and tragic situations and circumstances that you are like, my God, how can another human being live like this? How can another human being be in such a miserable condition? And it just doesn't make sense. And I remember when I had my first kid, some of you who've watched my channel for a while have seen him. He comes up in my video. Sometimes he's like hanging around my neck as I'm recording. And when I had my first kid, I thought a lot about, sometimes just randomly, I thought about like, how many other kids out there don't have a... It's funny because I promised myself that I wasn't going to be too attached to my emotions when I made this video. That was my intent. And I was just like, I probably didn't get enough sleep last night either, which doesn't help. So anyhow, with my kid, I would think, my God, like I can't imagine, some kids out there just have it so rough. And I think about the war in Ukraine and what it must be like for kids that just don't, because no kids really have an understanding whatsoever what's going on politically or whatever. And for them to be trapped in that environment, or like Afghanistan, like it's just so tragic. And I think similarly with patients in the state hospital. And I think it's so crazy how life can just give us an unfortunate circumstance, and then that's it. Like that's basically it. That's someone's life. And so the reality is, I don't hate talking about my experience when working at the state hospital, but I feel like every time that I really get into it, like I feel like I am now, I kind of relive some of that trauma, and I don't see a purpose to it, I guess. It's like when I'm thinking about kids out there who just have miserable lives or horrible parents or whatever. Like I used to go for walks around the state hospital. I'd go for this 30-minute walk to take a break. And once I saw this kid out there just playing with this toy, and he was kind of near the street, but his mom just freaking led into him. She berated him for being so close to the street. I'm like, sweet mother of God, called him all these names. He must have been probably, I'm guessing like 2.5 or 3. And it was like borderline, like it left me with a sick feeling in my stomach. Like, do I call social services? And I was left with this like conundrum. And I was thinking, man, I was like, well, in that situation, you have no idea what's really better for the kid, right? My point here, I guess, is that I don't like, what is my point, bro? Why have I been talking about this? And maybe some of you out there can share with me if you have a different view on this, but like, what is the point on dwelling on something that you have absolutely no power to change? Like, I can't change the fact that some kid in some African country out there is starving, despite it just overwhelming my senses, right? So I try not to think about it, but it's really hard for me to make a video when I've noticed and not be super attached to my emotions. So I'm going to try to rein it in. I'm going to talk to you about some of my experiences with some of the patients in this geriatric ward. So I guess I should just describe the ward. Like when you walk in, it's very old school. This ward is not updated like some of the other wards were. I mean, it looks like it's from the frickin' 60s or the 70s. Even the med room, everything is just old school. It looks retro. Like you feel like you're walking back into the 70s or the 80s. And I think for the total patients we had on this ward, it was might have been 12. Most of them were non-ambulatory, and that just means they couldn't walk. Ambulatory is the fancy word that nurses use and the medical profession uses to talk about someone who can walk. So if you're ambulatory, you're able to walk. If you're non-ambulatory, you can't walk. And I would say maybe we had 2 or 3 patients that were ambulatory, and if they were ambulatory, it was with assistance. Everybody always had a gait belt on, that little belt that goes around the waist to assist them if someone needs to walk them to the bathroom or whatever. And then everyone else was in a wheelchair, and everyone was always in, and I forget the name of it. It was, I don't want to say like 4-point restraints, because it wasn't 4-point restraints, but it was this belt that went around their waist and under their crotch to keep them attached to the wheelchair. So everyone was in that if they were in a wheelchair, because everybody was a huge fall risk on the unit, and everyone was on a ton of psychiatric meds, and most of them were fairly psychotic, and most of them, it's hard to say. I don't think anybody knows, but a lot of them probably had dementia, or they just had we were seeing the long-term effects of being on antipsychotic meds for decades. And my apologies if I'm repeating some information that was contained in a video I made months ago that's like 40 plus minutes about working on the psych ward. But I'm just going to go through each patient as they kind of come to me. So the first one I'm going to go through, we're going to name him Ben. And all the patients, I would say, were over the age of 60. Ben was a homosexual male. He was non-ambulatory in the wheelchair, always strapped in. He would perseverate, which is the fancy word for just obsessively think about something. He would perseverate about bowel movements all the time. Every 15, 20 minutes, he would say that he needed to use the restroom. And when I first started working this unit, one of the frustrating things is they had him on a schedule. I was like, how do you have somebody on a schedule? If you need to go, you need to go. I was like, I'm going to put you on a schedule. How would you feel? I didn't say it like that, but, I had this open-ended conversation about why we may not want to have someone on a schedule, some of the staff there. And it's like every 2 hours they would take him to the restroom. And even myself, like, I don't perseverate about any of that stuff, but sometimes I got to pee. Like, I just have to frickin' go. And I just feel like a lot of times we have no idea what's going on with someone's body, and maybe they do have to go. And one thing that just annoyed the heck out of me, and at least staff wasn't really like a dick about this. They were pretty cool. They were just like, hey, if you want to go help him, like, by all means, go help him, but we're not going to help him. We're going to help him every 2 hours. And these are people that work there on a consistent basis, right? I was on the pool, and they floated me to this unit, and that's why I was there. And I'm going to go on a quick tangent before we go back to Ben, because I want to share with why I was kind of working on the geriatric unit. And I felt frustrated working on the geriatric unit because it wasn't my thing. I don't like to wipe butts. I will do it if someone needs it, because I don't think it's fair to have someone just sit in their stool all day. But I don't like that kind of care. Like, that kind of bedside care is something you'd see in nursing care. I'm more of a psych nurse. I'm more really good at like de-escalating patients and helping patients who are in acute situations. And I felt like that did not exist whatsoever on this geriatric unit. But the reason that the hospital placed me there, and on this particular day, the very first day that I worked there, I went to 4 or 5 units when I was on the pool. And then I'd get there and the charge nurse said, no, we don't have you here. Call staffing, see what's going on. So I'd call staffing. They'd send me to another unit. And on that particular day, actually, I think I'm lying, because on that particular day, I just went home. I was like, you guys keep sending me to different units. I'm just going home. And I felt like when they sent me to the geriatric unit, it was retribution, because I was having so many issues on these other units with the way that I was seeing staff treat the patients. And I was fairly outspoken about what was going on and some of my concerns. And so people didn't want to work with me. And they're like, oh, here comes Nick. He's going to rock the boat. He's going to talk about how we're abusing patients, et cetera, et cetera. That's not really what they said. I'm just kind of giving you a quick like paraphrase. So they would send me to a different unit. And some people love working with me, because I think some people felt the way that I felt about the patients, but no one had the balls to speak up because they were worried about retribution. And other people, the people who were generally dicks, hated working with me because they knew I was lighting a fire on the unit and they didn't want to be part of any sort of investigation, stuff like that. So anyhow, long story short, I started getting sent to this geriatric unit a lot. And I think that was just like that's probably most people's least favorite unit to work on because it's like full care. You're doing everything for the patient. You're helping them to the bathroom. You're giving them showers. You're doing everything. They've got a lot of different treatments, nebulizers, frequent blood pressures, and just all sorts of different assessments because they're elderly and they're very likely to die, right? All right, so let me get back to Ben, and I'm just looking at my camera to make sure I'm not. Once in a while, my battery will just like all of a sudden be like, oh, it's low, and then it just shuts off. But all right, so let me get back to Ben. So when I got onto the unit with Ben, he was like, he would roll up to me with his wheelchair and he'd be like, Nick, I really need to use the restroom. I really need to use the restroom. And I'm like, okay, well, let's go to the restroom. We'll go use the restroom. And then, staff is like, well, he perseverates. He always thinks about it. He obsesses about it. Like you're going to take him and nothing's going to happen. Well, this time I took him and he had a bowel movement. I'm like, we've been sitting here this whole time. This guy's been saying that he needs to go to the bathroom and we're not doing anything. So that kind of irked me a little bit, right? But I can understand because he would ask very frequently, literally probably every like 15 to 20 minutes. Then he needed to use the restroom, and sometimes you would take him and he wouldn't go. But it's like, God, I can't imagine just being in a wheelchair all day and not being able to relieve yourself or feeling like you have or feeling like you need to relieve yourself, but not being able to just walk up and go. Like that has got to be so freaking frustrating. And there were some times when I would take him or some other staff would take him and they'd be like, see, he doesn't need to go. He's just persevering. I'm like, okay, that's fine. But I still feel like 2 hours is like a long time to wait. And I guess what really irked me about this situation is I could understand being on a schedule if we were super freaking busy. But a lot of times we weren't. Like the CNAs were just sitting around shooting the shit. And I'm like, okay, if you got time to shoot the shit, you got time to go check him to see if he needs to go to the bathroom. That's what I think frustrated me. And I get it, out of everyone in that hospital, the people who worked in that geriatric unit absolutely did the most work. So there's a lot that kind of goes through my head when I'm thinking about this, but still it was like one of those things that I found really frustrating. So let me tell you something about Ben though, because Ben said some pretty weird shit to me. Just some freaking weird shit that Ben would say to me. So one time, Ben strolled up to me in his wheelchair, and I might be confabulating a little bit. And if you guys don't know what the word confabulation means, it's a great word. It means like you fill in the gaps for memory lapses that you have, and everybody confabulates. So I might be, in other words, it's like a kind of a polite and professional, lawyeristic way of saying that I might be making shit up. But I'm not doing it intentionally. So some of this might be confabulation, but to the best of my knowledge, I promise this is the truth. So Ben rolls up to me in his wheelchair, and he's like, Nick, I can't hear the TV. Can you turn it up? So I say, sure, Ben, I'll turn it up. So I go over there and I go to turn the TV up, and Ben says something like, what did he say? Something like, I really want to suck your dick. And he does it under, we're in the day hall, and there was a few other patients around and maybe like one or two staff kind of in the area. And he whispers it to me like, I don't know if he said suck my dick or give me a blowjob. So that's confabulation. But he's like, I really want to suck your dick. And he did it like in that kind of voice while I'm at the TV. And so I'm thinking to myself, God, how do I handle this? And I'm trying to think like really quickly. And so I said to Ben, I said, excuse me, Ben, I thought I might have heard you say something. What did you say? Could you say a little louder? Kind of like own your statement, right? And then he was just like, no, nothing. I didn't say anything. But he would occasionally make these like weird sort of homosexual comments to me, which is another reason why people didn't want to take me to the bathroom, because he could be a little perverted. But that was the most curious part about Ben. And I don't think he was like making it up that he had to use the restroom. I genuinely feel like he had either a sensation or some sort of like psychosomatic, which is another fancy word for like it's up here, but it feels physical to you. Reason for that, he wanted to go to the bathroom. So I don't know. I guess if I were running the unit, just my general rule would be like, hey, if he feels like he needs to go, we could keep it to like every 20 to 30 minutes, assuming that we're not busy. Like, I feel like that's reasonable, right? But you could, like with Ben, I want to make this clear, like you could take him to the restroom, he could try to go, he could sit down, try to pee, whatever, and then you'd get him back in his wheelchair, and then literally 5 minutes later, I feel like I gotta go. So I could see maybe if you had worked on that unit for a year, how you're just like, sweet mother of God, bro, come on, we're gonna keep you on a 2 hour, like 2 hours though, it still seems like a long time to me. I don't know. Leave me a comment. What do you guys think about that? I'm curious. All right, now let's move on to Gabe. Gabe, I feel like I might have talked about Gabe in another video, but Gabe, geriatric patient, this guy was ambulatory, but I have never seen a patient who had so much visceral fat and almost no muscle tone on them whatsoever. And in other videos I've talked about where patients, when they're on large doses of antipsychotic meds and they're very sedated, how they just pack on the pounds over the years. That's exactly what happened to Gabe. And the best way that I can describe him is just a bowling ball shape. And I don't mean that in any sort of belittling or derogatory way. It's just he had so much visceral fat I want to say almost all over him, but you don't really have visceral fat all over your body. But he just everywhere. It was just a blob, and it's all from the antipsychotic medication and just being sedentary, not getting a lot of exercise. And what strikes me most about Gabe, and this hit me really hard one day. Like, I remember going home from work and thinking about it. Shit, I'm losing it again. I just got to be like a psychopath and not attach myself to emotions. That's what I need to do. So this is what hit me with Gabe. Like, one day I was working there and we had this custodian who was new, an older guy who lived in this city for many, many years. And he walks in and he sees Gabe and he recognizes him. And he's like, oh shit, that's Gabe, blah, 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 blah. And he starts telling me about Gabe. I'm like, he knows Gabe. And he's like, I can't believe that's, and he just, like, you could see it in his facial expression that Gabe had morphologically changed so much over the years. And not just his body, but his affect, his expression on his face, the way he was behaving, who he was as a person. I could see it on this custodian's face, like he was almost in shell shock from seeing him, like, oh my God, I can't believe this is the same guy that I knew 20 or 30 years ago from high school. I can't remember where the custodian knew him. And, he goes on to tell me about him, all this stuff. And I'm like, oh my God. And what really hit me was thinking about all the younger patients that I knew from working at the state hospital, who I knew that their prognosis was like Gabe's. They were going nowhere. They were going to be institutionalized for the rest of their life. They were on high doses of antipsychotics. They had a very flat affect. They had gained a lot of weight. They were drooling a lot. They were very slow cognitively. You could have a conversation with them, but just very slow. And I thought to myself, my God, all those patients, some of whom I felt very attached to and some of whom I kind of adored as a psych nurse, that was going to be them in 40, 50, 60 years. But anyhow, this is why I don't like talking about it, because it makes me feel really sad and I can't do anything to change it. It's frustrating. I'm just laughing because this has happened to me so much. Like, when I used to work at the state hospital, sometimes I'd wake up super early. That, and I think probably coupled with the stress of parenting and stuff like that over time. Holy sweet mother. But there were times I'd wake up and I would just think about this kind of shit. And I'd start crying. I'm like, bro, you got to be to work in 2 hours. Like, what are you doing? It's bad, you guys. It's bad. And trust me, I promise I'm okay. But when this is what I'm talking about. When I really get into it and I think about it, it just squishes my heart. That's the way that I feel. But some of these patients that I had become, that I was attached to that were younger, that's what hit me. Like, on my ride home, I would think about it. I'm like, fuck. I was like, that's going to be Gabe. Like, they're going to be Gabe's in 50 or 60 years. Like, that's it. And I think that's the tragedy of schizophrenia. And I know I've talked a lot of shit about psych meds. And yes, absolutely, the meds deteriorate them physically, mentally, and all that. And some people do benefit from them. Absolutely. But at the same time, that's the reality. For some people, that's the reality of their diagnosis. And whether or not they're medicated, their schizophrenia is so severe that if you didn't medicate, I don't know what their life would look like. They're so agitated and so affected by these horrible hallucinations. I really don't know what the quality of their life would look like. It's like choosing between a rock and a hard place. Both choices suck. It's like our politics these days and our presidents. Ooh. I wonder if I should mix politics with my channel. But it's just like there's no good choice. It just sucks. And that's what I think sucks. Like, having just two choices and that's severe acute schizophrenia is kind of like that. There's just, and I don't know. Anyhow, that's Gabe. I think I should move on to the next person. We had another guy in there who would always wear a helmet. Oh my God, I adored him. This guy was so adorable. And I can't remember why he wore a helmet, because even when he was strapped in his wheelchair, he had his helmet on. And I think it's one of those things where maybe they put a helmet on him because they were worried about him falling a long time ago, and maybe he became attached to it, and he ended up loving his helmet. And he kind of had the personality of maybe like an 8, 9, 10-year-old boy, but he was an elderly man, but just very lively, actually, believe it or not, and very fun. And he ended up passing away. It was very tragic. A lot of people missed him. And I don't really have much to say about him, just other than the fact that he liked to wear this. It was like a bike helmet, a very kind of thinner bike helmet that he wore around the unit. It was just kind of one of those cute things. You're like, oh, here's an old man that's wearing a bike helmet. And then just a lot of patients, I would say, on the unit, just kind of as I've raised kids, really remind me of toddlers. And a lot of these guys that are experiencing dementia or their brain is deteriorating over time. I mean, we had one in particular. This guy was, and actually, I mean, they remind you of toddlers, but it's kind of worse to some degree because, like, even with my toddlers, when I'm talking to them, although they might be able to communicate, or maybe 2 years old, whatever, although they might not be able to communicate to me, just as our geriatric patients couldn't communicate. I don't know if they had the same understanding that, like, say, a 2 or 3 year old kiddo does. Like 2 or 3 year old kids can understand a lot, but some of these geriatric patients, I'm like, I don't really know. But we had one guy, I mean, you'd have to sit there and feed him. Real adorable guy, but just like a toddler. I mean, would spill his food like a toddler, would throw his food like a toddler. And they don't do it intentionally. It's not malignant whatsoever. It's just that's where, I want to say, like, that's where they're at in their development. Developmentally, that's where they're at. Development is not the right word, though. It's like in their retrogression, that's where they're at. I guess one thing I wonder is I always have this curiosity as to what it's like to be in that kind of form of dementia. And then I always worry about, God, is that going to be me when I'm like 80 or 90? I wonder if I'll even make it to 90. And then it's like, what kind of life is that? I mean, just sitting there and not really being able to form a whole lot of sentences. Maybe you say 1 to 2 things and you seem kind of disoriented a lot and you just sit there all day. Like, that's it. The dude would just sit there. I mean, I don't know. Like, what kind of life is that? For those of you that have made it this far in the video, one of the nice things about cameras is that after 30 minutes, they stop recording. There's some weird law or rule or regulation about it. So you have to go back. I was getting pretty close there and have to restart everything, which is just obnoxious, but it is what it is. So, all right, let's talk about a guy named Mike. Mike was bedridden, morbidly obese, floridly psychotic all the time. I mean, this guy would just ramble about all sorts of stuff. If you've ever watched a 4 or 5 year old kid kind of get lost in their imagination, he was somewhat like that and just would talk out loud, would look around. I mean, and he was on a boatload of psychiatric drugs, like so much I couldn't even believe. One time I'm like, how much am I giving this guy? Which is the funny thing, right? Because in a geriatric unit, you would think the meds, they would try to decrease the meds, but it's like, at least in this unit, it was the opposite. I mean, this guy was on a ton of that liquid red Depakote, that really thick liquid. It's a mood stabilizer. Plus he was on, I think, like Zyprexa and clozapine, and then just a bunch of medical meds to address the side effects that all the psychotropic meds had caused him. I mean, it was crazy. And on the geriatric unit, you crush and everyone's dysphagic. They're all on a dysphagia diet, which is a diet used for people that have a hard time swallowing so they don't choke. So you would crush and float all their medications in applesauce, put them in this little thing, crank the lever, crush all their meds, put it in applesauce, stir it up, and then give it to them. And then they take their liquid Depakote. And then the water that you would use, that kind of thickening substance to help the water be thick so that they wouldn't choke on the water. And I just remember giving him his meds, and I'm like, my God, this guy's on so many meds. And I'm like, and then I would just think, like, what is the point? Because his psychosis doesn't seem managed whatsoever by these meds. And I was kind of like, well, or if it is managed, if his psychosis was managed by these meds, I'm like, my God, what did it look like when he was off his meds? His psychosis was crazy. What frustrated me about him, the guy was kind of a dick. A snarky dick that would say some funny shit. Don't get me wrong. Like, sometimes, and he would say some shit to me. I was like, he would insult me sometimes. I was like, that was a pretty damn good insult, bro. And I would, and so that aspect I kind of liked about him. And so that, for any nurses that are out there, by the way, that are watching this, like, when you have patients that are complete dicks or patients that have very few redeeming qualities to them, try to find something about them that you like in sort of an abstract way. And so what I liked about this guy, at least this is the way that I rationalized it to help deliver better patient care to him, is that he kind of didn't give a fuck. He was so lost in his mind. He's like, fuck this place. My mind's crazy. I've lost everything. I have nothing to lose. What the fuck? So I'm just going to speak my mind 24/7. I ain't got shit to lose. Like, that's what I kind of liked about him. Now, whether or not that was the case, I really have no idea. He acted like that, and I don't think it was intentional necessarily. There's probably not really intention behind it. It was more his psychosis, but whatever. Like, I attributed it to him, and I liked him more for that. Like, I could see beyond the stuff that a lot of people hated about him. And I mean, he could say some really snarky, mean things to people. And what frustrated me though, is like, as professionals, people are going to say that in psych, like that's what you sign up for. And what annoyed me is, and he would do stuff like throw water sometimes. He wouldn't throw it at people, but just like, I don't know. He would do a lot of stuff that was real snarky. But some of the gals that worked on the unit were just real bitchy to him, like straight up bitchy. And I'm just like, come on, like just giving him kind of like lip back. Yeah, was just floridly psychotic, always lying down, always had health issues. And like when you look at someone like that, I mean, if that were me, and I think 99 point something % of people would say the same thing. If that were me, I would rather have lethal euthanasia. There is no way being bedridden in his condition is any, like the quality of life he had was miserable. Plus his psychosis. And I just don't understand, like at that point, who's benefiting at that point? He certainly wasn't benefiting from being alive. And I say that with absolute certainty. The guy was in miserable condition. His psychosis was horrible. He was tormented by all sorts of stuff. I mean, sometimes he would just scream out in agonizing pain. And sometimes I think he was in legitimate pain. Other times I think it was his psychosis. And like I've said in other videos, there are sometimes you get these geriatric patients who are so tormented by their schizophrenia and meds don't really seem to help them whatsoever. And it's like, dude, what kind of life is this? And on top of it, to add all the physical ailments that he had, to be bedridden, not be able to move around whatsoever. I'm just like, what? I don't know. If I were a doctor, I would not lose sleep over signing some sort of legal euthanasia form with him. I can't imagine being in that circumstance whatsoever. But I don't know. It's one of those things where I guess it's kind of hard to say without being that person. And then when someone is psychotic and they're not in the right state of mind to give you at least some sort of information as to where they're at mentally, like how do you ever know? I guess I would challenge that perspective and I would say, well, look, you have cancer patients who are mentally with it. They're completely fine. And yet they're choosing to die. And their condition, I should be careful when I say this because it might not necessarily be true, but I would say, okay, fine. I'm going to say it because I think it probably is true. Their condition is nothing like this guy's condition over here, minus the fact that maybe their physical pains and ailments might actually supersede what he was experiencing, right? But still, like his psychosis and being bedridden, and I know he was in a lot of pain. I truly wonder how we justify that as a society, keeping someone like him alive. And that's a pretty strong statement, but that's me being real. I genuinely wonder what is our rationale for not euthanizing someone like that. I mean, obviously there's legal considerations, like where do you draw the line, right? And I think it's one of those things though, where if you really looked at his history and you looked at all the documentation and you had a chance to interact with him and you could watch him for some time, I think everyone would come to that conclusion. Everyone of sane mind would come to that conclusion, like, wow, this guy here, this is no way to live. Another patient we had, and I was kind of fond of her because I guess I'm kind of fond of patients, and maybe this is a little revealing of my personality because sometimes I feel like I can be like this, like patients that get under people's skin. And I think it's kind of funny because I think the way I view it is like, hey, if you're the professional and a patient gets under your skin, that's all on you, bro. Like that's personal work you need to do. Like you need to figure out what's going on such that you're going to let a person with this kind of condition and this kind of diagnosis get under your skin. And man, she could get under she could have people, I tell you, sometimes like the nurse would come out or a CNA would come out and they'd be so pissed. I'm like, shit, what's going on back there? And then you find out she's just being snarky with them. Like, that's it. One time I went to give her meds and she would just intentionally drop the meds and she would just like really do all this kind of poor me stuff. And she just wanted attention, which is totally understandable. Like, you're on that unit. If you could be on that unit, I think everybody on that unit wanted some sort of attention. She really wanted social attention. She wanted interaction and stuff like that. And she was actually very, very high functioning. She was probably our only, we had maybe a few that were like fairly high functioning. I shouldn't say all of our geriatric patients were demented or extremely psychotic, but she had, I think her diagnosis was maybe schizoaffective disorder with some borderline. She was very gamey, as they like to call it in psych. But it's just like, what is she going to do? She's strapped to a wheelchair, like, honestly. And so I always just thought it was kind of funny when staff would get so upset with her, but I'm like, she's just in a wheelchair. What's the worst that she could do? You know, if she's like going off and you could literally wheel her to another room and just say, hey, you need some space right now because the things you're saying to me, I find somewhat offensive. Like, you could do that and you could like, I don't know. But she would like drop her cup sometimes when you'd go to give her meds and pretend like it was an accident, and she just wanted attention and stuff like that. And I would kind of like call her out on it, but like in like just in an open-ended question way. And now that I'm making this video, I hope I'm not trying to portray myself as like a saint, because I certainly don't think I am. And I think one of the positives that I have as a nurse is I can kind of find humor in some situations that I think that frustrate a lot of other people, which gives me a lot of tolerance when it comes to just bizarre behavior or irritating behavior that sometimes patients will display. I don't even know where I'm going with this, but she was, I think what was kind of just interesting about her is she just always wanted attention. And when she wouldn't get it, she would just do like little shit, like spill drinks, anything she could do to get attention. She didn't care if she had to get negative attention. She just wanted some attention. So anyhow, that was her in a nutshell. I guess the last patient I want to mention is John. And it was interesting because at the state hospital, we had 2 different geriatric wards. We had one for ambulatory, higher functioning patients, and then we had one for the patients who were starting to physically deteriorate. And I had worked with this guy on the less acute geriatric unit. So I'd worked with him a number of times on the float pool. Well, eventually he started to deteriorate physically, so they moved him to this other geriatric unit, and he was pretty psychotic. You could have a conversation with him, but then you could see he would kind of look to the side, and you could tell that he was just getting lost in his psychosis and the voices and whatever. Pretty flat affect. Was a respectful guy. I don't think anyone really had any issues with his behavior or anything like that. But I just would always wonder with him, like, what was his understanding of being moved from that ward to this ward? Because the patient population was entirely different. And as soon as you, even as a staff member, like if you went from that geriatric ward to the ward where he was at now, you would see like, oh my God, okay, these patients may not live another year. And so I just wonder if he recognized that, like if he was coherent that this was the unit for patients who were deteriorating physically. Did he know that? And then if he did, what was his understanding of it? And where was he at? And I just, I never asked him these questions. I think I feel sort of saturated with this video right now. I feel like I need some downtime to process, if that makes sense. But I was always just wondering what his take was on it. And I feel like I'm kind of in tune with people, and I just look at his affect, watch his facial expressions now and then, and I just never got any sort of hint that it made a difference of what unit he was on, or that he had sort of any understanding of why he was at that unit and now he was at this unit. And that was just kind of like, I don't know. It's just sort of sad to think someone could be so out of it or so lost in whatever is going on with their schizophrenia that they have no realization of their own circumstance and situation. I shouldn't say no realization, but very minimal understanding of where they're at. Well, I think we're going to wrap it up, you guys. This has been an emotionally exhausting video for me. And when I started this video, I did not anticipate that was going to happen. I actually thought I was going to be able to keep my emotions in check. I found out otherwise.